I'm Dr. Anwen Cope, Senior Clinical Lecturer in Dental Public Health, and this is OPTIMISE, a Health and Care Research Wales funded study. Whilst half of people in Wales saw an NHS dentist in the 2 years before the pandemic, this leaves a substantial proportion of the Welsh population who don't access NHS dental care, and often these are the people in greatest need. When patients do see dentists, the focus is often on operative treatments such as fillings or root canal treatments, and the delivery of evidence-based preventive care is less consistent. However, not only are these treatments effective in reducing the burden of disease, they can be delivered by other members of the dental team, such as dental nurses or hygienists. And the use of the wider dental team in this way is called skill mix. One of the potential solutions that's been suggested to improve access to NHS dentistry is to shift resources away from low-risk patients to higher-risk patients by asking lower-risk patients to come in less frequently for their regular checkups. This might provide more capacity to provide more intensive care for higher-need patients, particularly provide them with more preventive treatments. This could potentially make NHS dentistry both more efficient and equitable. A large clinical trial recently reported that pushing the routine checkups for the lowest risk, healthiest patients doesn't adversely affect their dental health, but it's not known how much wiggle room is created in the system by pushing checkups from, for example, 6 to 12 months. OPTIMISE is a collaborative study between Cardiff University Schools of Dentistry and Mathematics, NHS collaborators and patient and public involvement partners. Our two patient and public research partners are active members of the study management group and have been involved in the design and execution of this research since its very earliest days. OPTIMISE aims to develop a web-based application using mathematical modelling to explore different ways of using existing clinical resource to deliver a preventive-led NHS dental care system in which skill mix is maximised. This work is aligned with a national programme which has been running since 2017 to explore different ways of providing and paying for NHS dentistry in Wales, called the NHS Wales General Dental Services Reform Programme. At the heart of this study is the creation of a web-based application called the OPTIMISE app. But lots of inputs are needed to inform this application how it runs. Firstly, we need to look at current clinical pathways within NHS dentistry. We did this through secondary analysis of routinely collected NHS consultation data submitted by practices to the NHS Business Services Authority. Once we've built up a picture of what's happening currently, then we need to generate clinical pathways in which there's the optimal delivery of evidence-based preventive care. We did this by undertaking a search and synthesis of UK evidence-based clinical guidelines, followed by consensus events with clinicians and patients. In total, we developed 21 clinical pathways which are based on patient age and risk of common dental conditions such as tooth decay and gum disease. When we know what's happening currently and what would happen under kind of a gold standard model, the next step is to work out the resource use in each. Our currency in this situation is time, from which we can generate cost. In order to know how long each of these pathways took, we undertook a primary cross-sectional study of 93 Welsh dental professionals, asking them to tell us the minimum, maximum and mean time of 55 of the most common clinical procedures in dental practice. And then the final thing we needed to input into the app was who in the dental team would do what within the clinical care pathways. We developed 3 models of skill mix use, ranging from a traditional model where the dentist does everything, assisted by their dental nurse, through to an intermediate model where the dentist works with their nurse but also delegates some simple tasks like scale and polishing to a hygienist, right through to a third model where there's a diverse dental team full of a range of roles and skills and everyone is used to their full potential. The web app and subsequent user interface were developed using an iterative process of testing by purposefully selected potential users. These are people who've got kind of dual roles in service and workforce planning, but are also dental practice owners. The technical name for the app that was developed is a demand and optimization model, and it sits on a website and looks like this. The demonstration of the model I'm going to present today is based on the profiles of 236,000 individuals who visited NHS Wales General Dental Services reform practices during July 2018 and September 2019. What we see is under the preventive-led clinical pathways, the number of clinical treatment items increase compared to current care. This is principally driven by a large increase in preventive interventions, particularly for the highest need patients. However, using existing patterns of skill mix use, preventive scenarios incur both more staff hours than current care and greater staff costs, which you can imagine is not particularly appealing for either service planners or clinicians. However, instead of having just a small dental team in which there's a dentist, dental nurse and perhaps a hygienist, you instead have a team in which there are dental nurses with additional skills and you employ a dental therapist who can start to do some simple fillings. You can deliver all the preventive care recommended by the current evidence-based clinical guidelines for almost a quarter lower staff costs. And under this final scenario, dental therapists and hygienists are delivering about a fifth of all care. So what does this all mean? Well, we know that the delivery of more evidence-based preventive interventions has the potential to reduce the future burden of disease. And furthermore, a greater focus on higher need patients may also reduce oral health inequities. What the OPTIMISE study has demonstrated is that it may be possible to deliver a preventive-led model of care using existing resource within NHS General Dental Services, but only if skill mix use is optimised. And this challenges previous policy, which has suggested that reducing the frequency of checkups for those lowest risk patients may alone be enough to free up sufficient resource to reorientate care towards our higher need patients. This work has important implications both for dental workforce planning, particularly the supply of mid-level providers such as dental hygienists and dental therapists, but also provides evidence about how changing clinical pathways impacts on resource use. We now intend to progress the implementation of this work with stakeholders in Welsh Government and local health boards and would expect the impact of this research to be seen at policy level.